And myself, I am Dr. Ashraful from Bangladesh Eye Hospital Institute, will be moderating the program. So thank you, dear guest, for participating. Dear ophthalmologist, we have changed the sequence of our talk. Our first talk will be presented by Dr. Sunita Chaurasia, madam, and she will be talking about dissect with simplified techniques. Sunita, madam, please share your screen.
Thank you, Ashra, for the kind introduction. Yeah, my slides are visible.
Yes, ma'am.
Yeah, all right. So I'll be talking on DSEC with simplified technique, which can be used for different case scenarios with predictability and good outcomes. Now, DSEC and DMAC are the foremost adopted endothelial keratoplasty techniques in the present times, and both have excellent outcomes. Now, when we talk about DSEC technique is easy to learn. It gives a very good visual outcomes and has versatile applications, and because it is applicable in most complicated situations, and is somewhat more endothelial friendly in some situations where you can expect to have more cell loss because of complex anterior segment. Now, DSEC surgery involves two major steps. One is the graft preparation, and second is the graft insertion techniques. Graft preparation again can be done by various methods, and graft insertion again we have various techniques like tackofold, using glides such as Busen glides, cheese glide, endocertus, and endoglides. In the dissection technique, in the graft preparation technique, I'll focus more on the manual dissection because I think that's more relevant, and automated techniques where there are other techniques using the femtosecond laser also. But let's move on to manual dissection. For manual dissection for DSEC graft preparation, we'll require lamellar dissectors, which are of two types: the Melis dissector, which comes from DORC, and they are long and the short. What we see in the picture, these are the Melis dissectors. There's a long one and there's a shorter one. There are reverse dissectors, which are straight and a little bit bulkier than the dog dissectors. And then we have the guarded blades, which could be disposable blades from BD, and it could be a diamond blade. So any of these things are fine. But what I have commonly used and find more comfortable is the dog dissectors, these ones, and the BD blade, which comes with the uh, guarded blades, which are 350, 400, 300. So you can choose depending upon your requirement of the donor cornea. Artificial anterior chamber again is of two types. One is of metal and one is the plastic one, which comes from the catena. Again, investing in metal artificial anterior chamber is better because these are much more. They can be used for a longer duration compared to the catena, which needs much more maintenance compared to the metal one. Now, the donor corneal parameters which we select for endothelial graft preparation is the graft should have a healthy endothelium about 2,200. Ideal would be 2,500, but 2,200 is fair enough. Age group for manual dissection, preferably about 10 years, because less than 10 years, the lamellar dissection may be somewhat difficult to dissect the cornea. Graft preparation, again, the rim should be actually good size. It should be at least regular rim of 14 millimeters. This is mainly because if we are using the catena artificial anterior chamber, it is designed to hold the corneal tissue, which has a scleroderm diameter of 14 to 18 millimeters. An ideal fit would be somewhere like a 16 millimeter diameter cornea. If the scleroderm is not adequate, fixing the donor cornea becomes difficult, making it difficult to dissect the tissue. So such a kind of tissue which has got an irregular rim and a small rim may not be suitable for lamellar dissection. Compared to the metal one is somewhat better because the metal one does not require a very huge rim compared to the catena one. So if you have to select between the two, a metal artificial anterior chamber is somewhat better over the catena artificial anterior chamber for lamellar dissection. Now there are some steps of manual dissection which are important. One should aim for a graft thickness of between 100 to 150, doing a mental calculation based upon the pachymetry. The initial groove should be around 6 to 7 millimeters groove at the limbus with a guarded blade set at approximately 80% depth, roughly around 350 to 400 microns. And if that is not happening with your blade, one can remove the epithelium, donor epithelium, which is about 50 microns to achieve the desired depth. It would also be good to identify the vertical axis of the donor cornea if you can, because that makes the initial groove at the limbus at vertical axis makes the dissection much easier. The chamber pressure while dissecting the cornea should not be too high and should not be too low, because that can inadvertently lead to difficulties, irregular plane perforations, and so on. Dissection using the two dog dissectors. The initial one, the smaller one, is used for the initial dissection, creating a plane up to the center part of the cornea, and thereafter the longer one is used for dissection far up to the periphery. So some difficulties one can encounter during manual dissection could be a superficial dissection, perforation, irregular planes. Now the key point is to get the right plane and to maintain the same during the dissection throughout. That will give a neat, clean dissection all throughout. Let's look at this video, and this is using the metal artificial anterior chamber. The cornea is placed. One can use BSS. You can also use the MK medium or whatever Cornisol medium or Optisol. And this is a dual lock to stabilize and make sure the chamber pressure is adequate. One important thing is that the guard of the blade should be towards the cornea, not on the conjunctiva, so as to ensure an adequate depth. The microkeratome prepared grafts are prepared from the eye banks, and the eye banks commonly use the Moria, and they are provided in the viewing chamber like this. When you get the cornea, the pre-cut cornea, it is important to handle the pre-cut correctly. Now, there will be a situation where you get the four orientation marks perfectly centered. And sometimes it may just so happen, especially if the graft preparation has been done a day prior or a few days ago, you may lose the marking or orientation mark. So it is important to identify where exactly is the center of the cornea, because a dissection with the Moria microkeratome is not up to the limbus. So we have to exactly pinpoint what the center of the dissection has been. Sometimes we'll get a cornea which has been dissected in a manner like this, where one ledge is a little bit larger, the scleroderm is larger. Now, when you stabilize this on your Teflon block or any kind of vacuum block you're using for trephination, if it is overhanging, it can lead to decentration. It is important to identify this and also correct it accordingly, so that the scleroderm does not override the block. Now, with the manual dissection, because we have the dissection from limbus to limbus, the centration may not matter so much, even though we should try to center it right into the apex of the cornea. But with the pre-cut cornea, because the dissection is around 9 to 10 millimeters, centration becomes very important. And sometimes when we get the tissue from the eye bank, it may be slightly eccentric. So it is important to know that sometimes you will see this kind of a ledge, and it's also important to remove this extra ledge of tissue while the punching has been done. So it is important to recognize, otherwise we may end up having some inadvertent issues while handling the graft. DSEC using the simplified technique, what I'm going to describe is about the pushing technique using the sheath glide, which is the commonest one which I have been using. And I think it's one of the simplest one because it's quite predictable. There is minimal to no chance of losing the graft polarity with this technique. You put the cornea on the glide using a mount of viscoelastic, and the orientation is almost always maintained. You will not lose the orientation at all in this situation. So it's quite easy technique, predictable, but we need to still understand certain nuances of the surgical technique. Now, the glide what we use is from the BD Visitech. It is available in two different sizes. One is 2.75 and 5 millimeters. I prefer to use a 2.75 one because it can go through the 4 to 5 millimeter incision easily. However, if you're using the 5 millimeter one can trim it because sometimes we don't require such a large width of the sheath of the glide. So you can just trim it to 4 to 4.5. Now, the surgical steps of the DSEC will involve the incision considerations, desmus membrane stripping, peripheral iridectomy, graft insertion, centration of the graft, and air tamponade for attachment. Incision is for the sheath glide technique, we need around 4.5 to 5 millimeters, depending upon the graft size and the donor and of the cornea, what we are planning to use for the given case. The location of the incision could be superior, temporal, limbal, or scleral, based upon the indication for which we're doing the surgery. Important thing is that the tunnel should be well constructed and should be self-sealing, and some planning of the ideal site based upon the case situation should be decided upon. Like, let's say this is a case of post-therapeutic PK eccentric graft. In this case, obviously, a temporal incision has been placed appropriately because it should be away from the graft host junction. In this situation, like in this situation of eye syndrome, where we have a trap done previously and two valves with extensive pass, a better situation will be to place an incision right at the limbus, right over here. So whereas because this area was completely full of synechiae and there's no other way. So incision, and in this particular case, clear corneal incision was done for the reasons that there's no space in the sclera. Descemet membrane stripping can be done either by using air, viscoelastic, or anterior chamber maintainer. Under air, it is slightly difficult to control, but viscoelastic gives a good chamber stability. There are certain cases where we can defer the descemet membrane stripping when it is optically clear. In this particular case of failed graft, we can strip it just internal to the graft host junction, not reaching up to the graft area, the suture area at all. So it is with the Sinski hook, we strip and bring it to the center. And final, once the 360-degree circumferential scoring has been done, it can be lifted up and pulled using a McPherson. Certain situations may happen where the posterior stromal bed is highly irregular. This particular situation, look at, this is a case of pseudophakic corneal edema with an ECC incision and a very thick, dense fibrosed descemet membrane. In this situation, it was not easy to peel off the descemet membrane, and in some cases, we may require a retractor to remove the fibrous descemet membrane. Inferior peripheral iridectomy, I think, is almost must, and we must do it in each and every case where we are going to have an air tamponade. It is a sure way to ensure that the patient has a comfortable postoperative period, and it prevents all the troubles of pupillary block and apposition angle closure that can happen in the postoperative period. So I prefer to do using a retractor inferior at 6 o'clock. And this is what I'm referring to. And sometimes if we don't do an iridectomy, we can have an apposition angle closure because of air migration behind the iris. In this situation, you will see that the air is behind the iris, and this can be easily avoided by making a PI intraoperatively. Here we can see a nice round PI, and the air bubble is above the meniscus, and there's no risk of having a pupillary block in this situation, the second photograph. Now, going to the actual graft insertion technique, I prefer using an anterior chamber maintainer, particularly when there is no need of stripping the descemet membrane. This was a case where there was anticipation of doing a glaucoma surgery postoperatively. So a limbal incision has been made, and chamber is stabilized. All steps have been done with the AC maintainer. 2 side ports are made, and if there are any pigments, we release them by using a single port. Sizing of the graft is crucial. We can put an air bubble and see the dimension of the graft that is required, and using the sheet slide with a mount of viscoelastic, preferably Healon, the graft is inserted inside, and once the graft is inside, put a small anchoring air bubble, center it, 1 suture, and make sure there's no interface fluid. Another similar case of a failed therapeutic PK post-infection. So in this particular case, again, we are planning a limbal incision. Again, in this case, since we are not, the descemet membrane is optically clear, we're not planning, we are not doing a DM stripping. Again, with the sheet slide, the graft is inserted and a small air bubble followed by a big air bubble with air tamponade, and making sure that the air bubble is complete in the anterior chamber. Now, caveats and strategies in different situations is one must obtain a good anesthesia. There should be no upthrust during this technique. The viscoelastic of choice is sodium hyaluronate because this is a cohesive viscoelastic and it's easy to remove it. If at all we are giving a wash, it comes out very easily, and it also it also protects the corneal endothelium much better than dispersive viscoelastics. Interface wash may be required in case we anticipate like some bit of viscoelastic has gone in the interface. It is good to give a wash. And foremost thing in the last, what is important is to make sure that the graft centration is with respect to the pupil. Now, this is a failed prior eccentric therapeutic PK graft, and desexcentration has been done. It's an eccentric graft, so desexcentration should be done right to the pupillary area and not to the previous graft. Since major part of the graft is well opposed, the attachment is not really a concern here, but for optimal visual outcomes, it is important to have the graft center to the pupil. So this technique works very well for routine cases of pseudophakic corneal edema where the chamber is well formed and chamber is stable and fuchs endothelial dystrophy. But it can be well applied to other indications also, like there may be many indications where we are planning to keep the patient aphakic. The DSEC and aphakia also. Now, few things to remember about this technique, about DSEC in aphakia is that air bubble management requires a special consideration. In these cases, it is not a good idea to overinflate the anterior chamber because it has a tendency to go into the posterior chamber, posterior segment rather, and cause difficulties of retention of the air bubble. Now, what works is that we can simply have a small air bubble, like in this particular case, a small air bubble, and raising the pressure above physiological IOP by just BSS injection and making incisions watertight. We don't need to have a complete full air bubble in the anterior chamber. We simply have a small air bubble and make sure all the side ports are watertight and just attach the graft by means of a balanced salt solution, which balanced saline, which can just be enough to cause tamponade, and simple air bubble, which is anchoring in the center part of the cornea, helps in attachment of the graft. So this is a maneuver which works very well for aphakic eyes. This is not aphakic case, but I just to show that. So something which can work as an alternative instead of having a complete air bubble, this technique works very well in aphakia. CHAD cases, the visibility being poor, and so DSEC is a good technique for these eyes. It results in good, excellent outcomes. This was one case. And phakic eyes with microcornea, this was one patient who had a 9mm cornea. Now, in a small eye, doing any kind of surgery can be challenging, but appropriately sizing the graft can work very well with this technique again. And there are some cases of pseudophakic corneal edema where you see a lot of membrane and there's a thick PCO. It's not that we have to do an IOL exchange all the time. We can simply clear off the center part of the thick membrane, followed by graft insertion. That can work equally well for complex anterior segment and disorganized chamber with decentered IOL. So this technique also works in such cases to give excellent visual rehabilitation. There are some cases, I just wanted to bring out this particular patient. Sometimes you'll see a thick fibrous tissue hypoplastic epithelium like this one. And if you do the OCT, overall you see a picture like this one where you can demarcate the epithelium from the underlying stroma. Now, these cases also can be planned for DSEC. And one thing to remember is that when you see a case like this one, almost always remember that you will not find the descemet membrane in these cases. There's no point in scoring the descemet membrane repeatedly because these cases generally do not have a descemet membrane. It may have been inadvertently lost at the time of primary surgery. Now, it may look like it's a very thick, dense cornea, but overall, in the long term, they do quite well. It may not give a very pristine clarity, but overall, the visual rehabilitation can be to a good ambulatory level. This is one case of progressive iris atrophy status post AGV, which was there in the posterior chamber. Now, following the surgery, the patient had a completely collapsed anterior chamber. The iris, lens, and the cornea was all adhering together in most of the part. So in such cases, if we have to do anything, we will have to manage the lens also and also reform the anterior chamber. So in this particular case, an extensive iridectomy was done with the phacoemulsification, followed iridectomy, followed by a graft insertion. This patient has almost like 6 years follow-up and doing very well after the surgery. Some of the other complex eyes could be cases like this one of iris cyst. Now, again, we'll have to manage the iris cyst first, aspirate the iris cyst, thereafter separate it from the corneal adhesions, form the anterior chamber, reconstruct by clearing off the iris cyst using a vitrector. And in this particular case, there was also communication with the posterior chamber. There was a lens, intraocular lens, and that is where it was communicating. So limited area was cleared in the posterior chamber, followed by, in this particular case, we have just trimmed the sheath well because it was a little wider. So similar way, just make sure like all side ports are watertight. Another case of a disorganized anterior chamber with iris cyst and vitreous prolapse. In some of these cases, now this was a case where there was a large iris cyst post-trauma, and you can also see there's a iris prolapse and some bit of vitreous prolapse at 6 o'clock. Now in this particular case, we had to first do a patch graft, stabilize the anterior chamber, deal with the iris cyst and cataract, and subsequently do a cataract surgery and along with the DSEC. So these cases do well with DSEC, and some of these cases which are not amenable to DMEC, DSEC gives an excellent visual rehabilitation in such complex eyes. Now, when we look at the endothelial cell loss with this technique, so far as the data of 2011-2012 is concerned, of patients with Fuchs and routine PBK, we saw that the cell loss was 25% at 6 months and 50% 5 years. I just recently happened to analyze the recent data for the more recent years where we have done DSEC with this technique. The cell loss was at 6 months to 1 year was roughly around 21%, which is slightly more than the TANS endoglide technique, but almost comparable to other techniques. So these would be my things about managing different complex situations with DSEC with this technique. Thank you.
Thank you, Dr. Sunita Chaurasia, madam. Thank you for your excellent presentation. So, as you know that in Bangladesh, most of the surgeons were doing PK and DALC. So hardly 25 DSEC endothelial keratoplasty has done. So what will be your advice for the beginners who want to start DSEC? What should be the cases they can start with?
Yeah, I think the early cases should be little better ones, like they should not be very complex anterior segment and all that. It should be a stable IOL, stable anterior segment. Considerations are most important because that can give a trouble. That needs some bit of a, in situations where the iris and the lens is not very stable. So one will have difficulty in stabilizing the air bubble and getting a good outcome. So I think it should not be too complex. Fuchs can be a good indication certainly, and PBK with a decently okay anterior segment. So those kind of cases should be very good for beginning cases because both these conditions, DSEC gives an excellent visual rehabilitation for any of these cases.
Thank you, ma'am. I would like to invite Dr. Somashilamurthy, madam, for his comment and opinion about DSEC surgery.
Thank you very much, Ashraf. First of all, thank you for inviting me, and I'm so happy to be part of this forum. Sunita has given an excellent talk on, and she's literally covered all aspects, starting from the simple techniques, as she mentioned, and then going on to, she showed us a lot of complex cases that she does. She's a surgeon par excellence, so we know that she makes these cases look very simple, but they're not. So I think that the simple techniques that she mentioned, those are the tips that all, especially those who are in the initial part of the learning for DSEC should take home. And the idea is to use these techniques, especially I would say that the top 4 things that we should do is ensure that you select the technique, which is ensure that you select a case which is a sort of a beginner's level case. Don't take the cases with irises and so on, but a straightforward case of Fuchs endothelial dystrophy or PBK should be your beginner level cases that you should start with. And second thing to do is use simple techniques, use a larger incision. So don't go with a small incision. Firstly, because when you push the lenticule in, you'll have more distortion and folding, and you'll actually lose endothelial cells. And secondly, it is difficult for us to manipulate through that. I would also recommend the Sheets glide, which is very simple technique to use. Although Dr. Audrey, who's here, has another beautiful technique that she uses, and she's demonstrated to us when she does her D6 of how not to use the Sheets glide, but to get a very good push in technique of the lenticule. But Sheets glide is easily available and you can do that. And always suture at the end of the case. Try not to make a sutureless incision, a self-sealing incision, because you will be injecting quite a bit of air and you want that air to stay post-operatively. I think these are good techniques for all of us. We keep doing them even now to get like a no-brainer kind of DSEC with no problems. So thanks, Sunita, for putting it together so wonderfully.
Thank you, madam. Dear ophthalmologists, now we are going to our second presentation. The second talk will be done by the Dr. Adreti Rostam, madam. She will be talking about DMEC step by step.
Great, thank you. You can see my slides here. Perfect.
Yes, ma'am.
Great. Okay, we can see that there's lots of friends here on the initial photos, and I'll be talking about DMEC techniques. Thank you so much for this invitation. It's great to be halfway around the world this morning in Bangladesh. I wish I was able to be there in person with all of you. When we talk about tissue prep for DMEC, we really want to try to use older tissue to have some sort of stamp, either an S stamp or a P or some letter or F or some letter where you're going to be able to differentiate which side is which, endothelial side from the other side. Obviously, you don't want to use an A for obvious reasons. You want to be sure there's adequate staining of tissue. And you also want to be careful about the patient head position when you are inserting the tissue. We'll go through this slightly later. And so I want to thank, let's see here, Dr. Praveen Vadavali for this video. And this is demonstrating the technique. You first use about a 9 or 9.5 trephine. You then go with your dialer or Sinski hook after adequate staining. You lift about halfway and then you cut again to the desired point. You use a small punch trephine, 3 millimeter, and then you cover back your Descemet's membrane. And then what you do is you flip the tissue over, and then you have your little window. And once you have your window, don't know where the video is here. Let's see again. Here we go. And so here we have placing the tissue down. You want to mark the centration, and you dry with a little sponge. You mark the centration, and then you want to center your tissue right here. And it's really important to be sure that the tissue is centered. It's extremely important. And you want to take a look and make sure that you have a good rim all around. And then you're going to go use the trephine. So once you're happy with the centration, there's no folds in the Descemet's membrane there, things are looking good, it's oriented nicely, you then use your 9 or 9.5 millimeter trephine and trephine the cornea, which you'll see here in just a moment. Following the trephination, and you want to be sure that it's even all the way around. You can do a little tapping and just be sure that you have an even cut, because you don't want to be cut in some areas and not the others. Following this, you want to be sure that you have adequate staining with the trypan blue, and depending on where you are, it depends how long this takes to stain. And then you can take a dialer or Sinskey hook, and you want to start with that and with your small forceps and go essentially all around. And then you can start to lift the Descemet's membrane. You want to be very gentle, firm enough, but very, very gentle to be able to complete this task. And you can see here is the lifting. And Dr. Praveen makes this look just absolutely seamless. This is where you have to be super careful with the lifting. Otherwise, if you have tags and such, you can actually tear the tissue. So just the gentle lifting there, and then you go around, and then you can turn the apparatus so that you are making that easy for yourself as you are gently lifting all the way around there. And usually you leave one spot where you still about 1 clock hour of attachment, where it's still attached. And again, just lifting very, very gently. What you want to do after this is you want to go about halfway or so, just enough to be able to then create a little window. And so the goal here is to use then a 3 millimeter trephine, which we'll see in just a moment. Again, lifting. Let's see if we can. Here we are cutting the tissue again, just cutting that to the desired trephination size, which you can do then or afterwards, either way. Can go through this a little bit faster. Restaining. And then this is one of the key points here, is then creating the area where you want to mark. You really need to mark. I know some people don't mark their tissue. I find it unbelievably difficult if you actually don't have some sort of orientation mark. And so there is with the little trephine, you have your, it's like a dermal punch. You take your window, you then place it back, and then you place your DMEC graft back, and then you're going to gently turn it over flip it around so that you can make the mark. And so you have your little window, and the little window you can then lift up. You want to be sure it's dried underneath, because if it's not dried, then you will have a problem maintaining the mark. And Dr. Praveen likes to use a P, which is a good orientation mark. Again, whatever letter is your favorite letter to use that has some sort of orientation is a good one to choose. And then there you have it, you've got your graft. So once you have your graft, the next step is to do the bed preparation. You want to determine the size of the graft to be used. You want to measure it with calipers, mark the cornea, and we'll go through these step by step here. You want to score the Descemet's membrane lightly, and as Dr. Sunita said, you can use, just the same as with DSEC, you can use an AC maintainer, which is my preferred method. You can use air, you can use viscose, whatever your preference is. Be consistent, try all of them. I prefer the AC maintainer. For DMEC versus DSEC, you want to strip the area larger than the planned graft size. And the reason for that is because Descemet's does not stick to Descemet's. When you have a situation where there is a previous PK size 1 millimeter smaller than the original graft, for example, if you had an 8 millimeter original graft, consider a 7 millimeter DMEC. Larger grafts are much more difficult to unfold, and beware of pass. Again, you want to measure the area with calipers and mark that, and be sure that everything is centered on where you want the graft to be. In terms of techniques for creating your descemetorexis, again, you can use irrigating instruments to score and strip Descemet's membrane, and this is for DSEC or DMEC. You can use a reverse Sinskey. I like to use, there's a MST makes a very lovely little micro forceps. It's also available in India from Focus Ophthalmics and iZone. I have no financial interest in this. You can also use a reverse Utrata. But I like the little Descemet's membrane forceps, which you'll see, because also if you happen to have an issue, a wrinkle or something in the Descemet's membrane, you can fix this easily. Remember, do not press too deeply. Do not strip the stroma, especially for DMEC. In DSEC, you can cover some mistakes and you can cover some errors there, but with the DMEC, it's not so friendly. So you really, really need to be careful that everything is perfect. If you start to see some stromal fibers, then stop and then apply more gentle pressure. Again, larger than the size of the graft. For DSEC, it doesn't matter. You can do the same size. And again, with DSEC, it's easier to cover your mistakes. DMEC is really not the same way. Here is just marking the cornea. So you can see, again, that's the marking right there. And then with a DMEC or DSEC, I like to make 3 paracentesis incisions, so 3 side port incisions. I use a very small diamond blade. Disposable blades are fine, obviously, as well. I use an AC maintainer, and then you can see here just the scoring of the Descemet's membrane. And then I'm very, very careful. I'm going beyond where my marks are, and so beyond there, and that way you'll be able to make sure that you have an adequate area. And then following the stripping of Descemet's membrane, I use trypan blue. I inject trypan blue afterwards to see where I may have missed any areas. And so with either a reverse Sinskey or with a Descemet membrane forceps, you can use any of your side ports. It makes it very, very easy and facile to make sure that you have a complete stripping of the Descemet's membrane. With a little forceps, you can also go back and grab the Descemet's membrane as well. You start to peel it. You can actually do this all just with a little Sinskey as well. With a DMEC, you want to be careful around your side ports. With a DSEC, you can actually cover the side ports with the graft, but not so with the DMEC. So you just want to keep that in mind. And here you can see just removing the Descemet's membrane. And again, you want to make sure that you have a nice clear area. After you inject the trypan blue, and you can then flush it out because you have your AC maintainer, and you can see if you have an adequate area. If you've got a little tag or a little skip area, you can easily go back. So again, remember, Descemet's does not stick to Descemet's. You then also want a miotic pupil and to create an inferior PI. What about tissue insertion? Well, there's different ways you can insert DMEC tissue. I prefer the Gutter cannula. You want to be sure that you check the orientation of the tissue before you insert it and insert the tissue in the direction of the fold. You can also use a modified Jones tube, or you can use an IOL cartridge. You want to insert away from the pupil. And one of the main things is that when you're unfolding, you want to be sure that you have a shallow anterior chamber. That is one of the keys to success. And this is an entire You can see scoring Descemet's membrane here. Again, I like to use an AC maintainer here. I then make an inferior PI with tooth forceps and scissors through my inferior paracentesis. And the main incision then is created with a keratome. This is peeling the DMEC graft from the cap. Easy to load it into the Gutter cannula. And then I try to orient the graft facing upward. Again, bevel down past the pupil, and then orient the bevel of the cannula in the direction you want to insert your graft. That makes it so much easier. You want to be sure to wait a couple of seconds before you withdraw the cannula, and then you can just tap. Make sure that your chamber is shallow enough, and some tapping there, little gentle tapping. And you can see the orientation marks there. You want to be sure you have the graft centered, that's key. And as you can see, I already created room there, and I've placed a suture. With a 1 or 2 cc syringe, inject a small air bubble, and before you inject a larger air bubble. And that's really important. Remember, air is not your friend. Also, do not insert a DMEC graft into an overpressurized eye. And if there is resistance on insertion, then do not force. Let's see here. And this is the reason why here. If you encounter too much resistance, just stop, because it's really makes you less happy when that occurs. Unfolding the tissue, also known as a DMEC dance. You want to make sure you tap, don't swipe. It's not Tinder. I don't know if you guys have Tinder there, but you basically do tapping. If it's not unfolding, there's really only a few reasons it's not unfolding. Either the chamber is not shallow enough, which is most commonly what the issue is, or the tissue may be upside down, or you could have fibrin may be present. You can do a carpet roll, you can tap if it's a double scroll, And if it's upside down, then short bursts of fluid can be helpful. And you can get fibrin in the AC from vigorous unfolding or tapping on the iris too much, or from the inferior PI. You can restain the tissue if you need to, and remember that air is not, in fact, your friend. We'll watch some of this here. I want to be careful about time. This is what can go wrong or how to correct it with the DMEC. Sometimes your DMEC membrane doesn't come out in one piece. But then let's get to the good stuff. And so again, inserting the graft, usually not a problem, but sometimes if you're not careful about the orientation, then what can happen is you can end up with more challenges than you would like. Little bit of pressure. I'm a little concerned here, but then seems to go in. And then again, you want to wait a couple of seconds before you withdraw the cannula. And then you want to be sure that you place a suture, because it's really not a good thing when your DMEC graft comes shooting out at you. And here you have a little bit of a carpet roll. And so you want to try to unfold that. Sometimes it's a very, very tight scroll if you use younger tissue. You can also have the opportunity to see if you've in fact unfolded it upside down. And there you can see that's why you have the orientation mark. Not a problem. You can go back and you can just do short bursts of fluid there. So you can see short bursts of fluid. And eventually you can get that to cooperate. And sometimes it takes a little bit, and just short bursts of fluid. And you don't want to actually carefully, you want to be sure you're not touching with the cannula, the tissue. And then you can see it went to the right side, and you just have to get it to move over a little bit to orient the graft. Sometimes a little bit of digital pressure at the equator can also be helpful. And there you have your DMEC dance, and then a little bubble and then a bigger bubble. Avoid injecting air into the pupil. You can use air or gas. I've just always used air. Be sure that the inferior PI is patent and visible. You want to leave a larger air bubble in general with the DMEC compared to a DSEC, but do be aware for the potential for pupillary block. When injecting the air, if you have a previous PK, and this is with a DMEC or a DSEC, you want to be a little bit careful, because what happens is you can get this, and that's rupture of your PK wound. So you want to just be a bit careful there. So that's never a happy thing either. So just be aware that that can occur with DMEC or DSEC. Not that it's ever happened to me. And then you want to be sure you suture your original PK wound should that happen. So pearls for DMEC, S or other stamps, pre-cut or preloaded tissue is what I use because I'm able to in that position. Patient position, you want to be sure that everything is in a flat plane. Another reason for your graft not opening or for your having difficulty or struggling is because your patient's head may be tilted, they may be, their chin may not be, maybe too forward, it might not be back enough. You want to make sure you have 2 paracenteses. There's only 3 reasons really for not unfolding. Usually it means your anterior chamber is not shallow enough. You may have an upside down graft or fibrin in the AC. You can do the tapping and trapping or the fluid to flip or open, and air is not your friend. And the reason I say that is because if you inject too great an air bubble, you can actually just shift the graft over. You want to be sure that you're underneath really centered on the tissue, but also don't inject it so forcefully, because then it can go through the pupil. And there's what DMEC and DSEC looks like. and I thank you. Thanks so much. Appreciate the opportunity.
Thank you, Audrey, madam. You're always an excellent teacher, and it was an excellent presentation. So we have few questions, but right now I want to ask about two questions. You know that in Bangladesh, we are very much dependent on the foreign tissues. We are very much grateful to Vision Share and Sight Life for distributing tissues with us. So what is your suggestion when we want to do DMEC in the foreign tissues? So what should be our consideration, number one thing? And number second thing is, what should be a beginner surgeon who wants to start DMEC should look for a patient? What should be the patient selection criteria?
Well, I think that in terms of the tissue, you want to choose older tissue over like 60 years of age to start with, because it will be less of a scroll, at least over 50, but over 60 really is ideal. And that's going to be a lot easier to use. Also, a higher cell count is also good because there is cell loss, especially in the beginning when you're in the learning curve. And so I'd say those two things for tissue to look for would be really important. That here older is in fact better. And so I would say that that's important in actually looking for the tissue. Patient selection, if possible, if you have a patient that is more simple, if you have someone who simply has either a Fuchs dystrophy or endothelial cell failure, you should make sure that you have an adequate view in. That's the real difference between a DMEC and a DSEC. As Dr. Sunita really just beautifully demonstrated, even if you have a terrible view with the DSEC, you can still really get a lovely result. With DMEC, not so much, especially with a dark eye. It's really hard to visualize if you don't have a good view in. So I would say be sure your view is adequate. Don't start your first DMEC on an eye that has lots of pus and may have vitreous in the anterior chamber, you're not sure, an unstable IOL or an ACIOL. That's not your first case for DMEC. You want to have a relatively good view and just a more simple situation if possible.
Thank you, madam. Thank you for your nice presentation. I would like to invite Dr. Sunita, madam, for your input about DMEC. Sunita, madam, can you please hear it?
Yeah, sure. Sorry, did I miss something?
Oh, I would like to request you for your input about the DMEC surgery.
Yeah, I think if you look at DSEC versus DMEC, I think the prerequisite is that you should have a good visibility. So wherever you have a good visibility, I'm sure most of the cases you can manage. And yes, of course, a stable anterior chamber, the lens IOL diaphragm, the lens iris diaphragm should be stable. That would be the prerequisite. Most cases of where even the complex cases where we were doing DSEC earlier, we can manage with the DMEC, but then it's important to understand which cases, which will be safe for DMEC surgery, because it's not just that getting the surgery done, it is also looking into how much is the cell loss. So I think that this distinction one should be very clear, which cases to schedule for DSEC versus DMEC, because it's no point in just having a surgery but having more cell loss. So I think certain cases where you expect a more cell loss, it's better to plan a DSEC, and more better eyes with a stable anterior chamber and a good visibility. It is good to plan DMEC in those eyes, because obviously the results are greatly different between the two. The results are far quicker, and you always have the advantage of lesser risk of rejection with DMEC. So that would be my take on deciding upon which cases for DSEC versus DMEC.
Thank you, madam. Our panelist, Dr. Sayyade Hassan sir, just SMS'd me due to unavoidable reason. He cannot join with us, but we are very glad that in Bangladesh, few surgeons have started DMEC and DSEC surgeries. And in last 2 years, we have done around 10 surgeries. And I would like to take Dr. Rashid here. He is one of the surgeons in Bangladesh who did few DSEC and DMEC. And I would like to request Dr. Rashid to share his story to our respected panelists with very short. Dr. Rashid, please unmute yourself. Yeah.
Hello, can you hear me?
Yeah, Dr.
Okay.
Rashid, we can
So
hear you.
doing in
So please share
2019,
your
yes.
story that why you started the DMAC in where
Okay.
is not available here. Dr. Rashid, please.
So the thing is, when I went to the that is ACS meeting in Seoul in 2016, so there was lots of presentation. I think most of more than 50% of them were lamellar keratoplasty. So all the talks were going over my head. So I decided to do what is this and do some wet lab in 2017 with under James, and in 2019 Vikash Mittal came to our institute to teach us about the DSEC and DMEC. We did extensive 3 days, that is wet lab and live surgery. And after that, I went to Bashak sir's, that is Disha, and stayed there for one long whole day for observing some few cases of DMEC. So these are the initial things I did. And after that, in 2019, in December, I did the first DSEC. And then after 4 DSEC, I did first my DMEC in
I think the signal like
2000. So I have done 4 DMEC so far. And luckily I was a lucky beginner. All that it did not get that well because of the I think the patient selection was not that good. It was very hazy cornea. So yes, I think that it's the mindset and the believe in yourself. You can do the DMEC and DSEC also.
Definitely, Dr. Rashid. Thank you very much. I think our surgeon in Bangladesh also will come forward for these surgeries, and we will talk about it later at the question answer session. Now, I would like to invite Dr. Rajesh Fogla sir. He is a big name in Bangladesh in our cornea surgeons. Dr. Rajesh Fogla sir will now talk about tips for successful big bubble dive.
Thank you, Ashraful. At the outset, I would like to thank Bangladesh Eye Hospital for inviting me to be part of this webinar. And I will try and share my pearls on how to perform successful big bubble DALC. And I'm very happy to hear that more and more surgeons are doing DALC and PK. And usually when we train people both for DALC and DSEC, they always go back and do DSEC first, and they find DALC to be a little bit more challenging. But I guess you have more surgical expertise, so you're able to do your DALCs much faster. Now, when we talk about big bubble DALC, I have no financial interest to disclose. The deep anterior lamellar keratoplasty is a surgical technique wherein you replace 90% of the corneal stroma with donor tissue, leaving behind the healthy, intact Decimex membrane and the endothelium of the host. So the biggest advantage is that there is no risk of endothelial rejection. So you need to use steroids for a shorter duration of time. The surgery is performed in a closed chamber, reduces the risk of intraoperative complications compared to full thickness penetrating keratoplasty. Because the risk of rejection is low, you can do much larger graft, larger diameter grafts. And also the availability of tissues from the eye bank is also much easier because you're not looking at very high cell counts. This report published back in 2011, it showed that the outcomes of DALC are comparable to penetrating keratoplasty, superior to PK in looking at the endothelial cell density preservation. It has safety margins compared to PK and good for visual rehabilitation wherever in conditions where the endothelium is still healthy. Among the surgical techniques, you basically have 2 techniques. Either you use stromal injection of air, viscoelastic or fluid to give exposure to the pre-Decimex layer, what was earlier thought as the Decimex membrane, or you can do a layer-by-layer manual dissection to come very close to the Decimex membrane. The big bubble technique was described by Mohammed Anwar back in 2002, along with Dr. Klaas Teachman. In this technique, 27 gauge needle tip is introduced at about 80 to 90% depth of the corneal stroma, and a forceful injection of air is given, which results in separation of the stroma with what was thought at that point of time to be the Decimex membrane. So Professor Dua's work in 2013 showed that when you inject here, you get a different kind of bubble. The type 1 bubble is something that forms between the stroma and the predecimates of the Dua's layer. It starts from the center and expands outwards, has a dense white frothy margin. Usually attains a diameter of about 8.5 millimeters. The type 2 bubble is something that it can start from the periphery and it can go across the cornea. It has a very sharp, clear margin, unlike the type 1 bubble, which has a dense, frothy margin. And here the separation is actually between the decimus membrane and the predecimates layer. And you can have a mix of type 1 and type 2, also referred to as the type 3 bubble, where it starts off as a type 1, and then as the type 1 bubble is expanding, it can form a type 2 bubble. And that's the type 3, where you see multiple separation. In terms of the preoperative evaluation or case selection, I think it's important to see on slit lamp, and if you have a corneal scar, to see whether the scar is superficial or goes all the way to the decimus membrane. Like in this case of keratoconus, you can see that the scar is involving the decimus membrane as well. A better way of estimating this is using the anterior segment OCT. So if you look at these 4 anterior segment OCT images, these 2 are okay for air injection technique because the scar does not involve the decimus membrane. But the other 2, you can see there is some involvement of the predecimus layer and the decimus membrane. So there, if you try to do an air injection, you're more likely to have complications where you may get either a formation of a type 2 bubble, or you can get a type 1 bubble that starts and then you can end up with a spontaneous rupture. So the common indications in our clinical practice are basically ectatic disorders, advanced keratoconus, post-LASIK ectasia, sometimes pellucid marginal corneal degeneration. We do see stromal dystrophies, out of which I think macular dystrophy is something that gives unpredictable response to air injection. You can have corneal scars following trauma or infections, which are not involving the decimus membrane. So in terms of air injection, I usually avoid in very advanced keratoconus where the cornea is thinner than 250 microns at the apex, or there are scars involving the decimus membrane. Basically, in advanced keratoconus, the predecimus layer is already stretched quite a lot. And there, if you try to inject air and stretch it more, the chance of a type 2 bubble or a spontaneous rupture is much higher. In terms of surgical planning, you need to have some idea about the corneal thickness, the regional pachymetry across the cornea. You can use various tomography or anterior segment OCT to look at the regional pachymetry. And based on this, you can decide on the size of the trephine you're going to use and up to the depth, what depth trephination you're going to perform. In terms of the various trephines that you can use for planned depth trephination, commonly we may be using the regular handheld metal trephine, but these trephines, you cannot have control over the depth as to what depth the cut is. But you have these guarded depth handheld trephine, which are available from Coronet Network Medicals, and these can have preset depth of about 300, 350, or 400 microns. And you can use that to achieve a partial thickness trephination without the risk of perforating the anterior chamber. The common trephine that we use is the Hesburgh-Barron suction trephine, which are available from various companies like Catena, Jedmed, Surgistar, and Moria. Here, each quarter turn of the trephine cuts down a depth of 60 microns. So usually about 6 or 7 quarter turns gives you a cut depth of about 360 to 420 microns. So the usual trephine diameter that I prefer to use is varies between 8.5 and 8.75 millimeter in diameter. Moria has a trephine where you can preset the depth so that you don't have to remember the number of turns that you make. So you can turn the metal knob and preset the depth to 350 or 400, and then you can just rotate the knob without having to worry about whether you have gone a few turns extra or you've gone a little less. It will basically stop at the desired depth. If you have access to a femtosecond laser, you can use that. The advantage is you can make shaped peripheral cut in like a top hat or a mushroom or a zigzag. And in certain cases where, like pellucid, where the thickness is variable, we often use a diamond knife to make the initial groove. So you can set your diamond knife based on the pachymetry to the desired depth, make an impression with the trephine, and then go along the trephination mark to make your groove. In terms of making the mark, I like to use a pair of calipers, make 2 marks, horizontal and vertical, using the desired trephination size. Like in this case of post-LASIK ectasia, I'm using a trephine of 9 millimeter. So I make my 2 horizontal and 2 vertical marks. And then when I put my suction refine, I try to touch all these 4 points rather than just trying to follow a central mark, which can sometimes give rise to parallax error and you can have an eccentric refination. So here you can see that we have gone about 7 quarter turns. So that's about 420 microns, but you see my cut has gone through those 4 marks that I make. And when you retract the cut edge, you can see that it's a fairly uniform cut all around, which is again the desired depth that you would want when you're doing a big bubble dive. I also like to do an anterior lamellar keratectomy to debulk the cornea before I do my air injection. The advantages I feel are that by debulking 40 to 50%, you reduce the chances of stromal emphysema. It also improves the depth of placement of your cannula as compared to when you place your cannula without doing the keratectomy. You may be thinking that you are deep enough, but you're usually at about 60–70% depth. But if you debulk 40–50%, then when you put your cannula, you're usually at a depth of about 80–85%. However, in certain cases, if the apex is very thin, then I avoid debulking, because by debulking, you remove a lot of stromal tissue from the thin apex. And then when you inject air, the air comes out anteriorly rather than going posteriorly. So the debulking can be done you need not remain in the same plane, but you can just use any lamellar dissector. Be careful when you use a crescent or something, because the crescent is very sharp. So if you try to do, if you don't have control over it, you can end up perforating into the anterior chamber. In terms of air injection, yes, you can use a needle, a 27 or a 30 gauge needle, and the success rate reported with the needle ranges between 65 to 70%. But the problem is that the needle tip is very sharp, and if you keep it very deep, any kind of movement of the tip can result in the tip perforating into the anterior chamber. So I find using a blunt tip cannula, which is a bottom port, to be much more safer, and it's quite reproducible. The other instrument, because it's a blunt tip cannula, you need some form of instrument to initiate the track. So I'm going to the base of my trephination. I stabilize the stromal tissue. Then I use the pointed dissector just to break the stroma at the base to create a small track. And then I introduce the air injection cannula, which is attached to a 5cc syringe. And as you inject air, you feel an initial resistance, which gives way, resulting in the formation of the type 1 bubble. And you can see that white ring kind of expanding outwards. You continue injecting air. And the only thing is that, sorry, I think maybe the next one. Let me show this video first. So when you're injecting air and you're going outwards, you will feel an increasing resistance. That is because the aqueous has nowhere to get displaced. And if you feel resistance and you persist with enlarging the bubble, often you can end up perforating the anterior chamber, because the counter pressure from the aqueous has been quite a bit. So let me explain in this diagram. So when you put your cannula in and you're injecting air, you get the formation of the bubble. So you have pressure within the bubble and you have pressure within the aqueous, which is trying to prevent the bubble from expanding. As you inject more air, the pressure within the bubble increases as the counter pressure in the anterior chamber also increases, because the aqueous is not getting displaced anywhere. It's a closed chamber. Now in this scenario, if I continue to inject more air to expand the bubble, the intra-bubble pressure increases more, and you can end up the posterior layer rupturing with air entering into the anterior chamber to normalize the pressure. So to overcome this, what we do is that we do a sequential injection of air. That means we do the first injection, and when we feel that there is resistance, we then do a paracentesis to release aqueous, and that by releasing the aqueous, you reduce the counter pressure. And then when you go and inject air, you can expand the bubble without the risk of the bubble rupturing. And this also, if you look at this paper, which is published in Asia Pacific Journal of Ophthalmology 2017, in lab experiments, they have shown that in artificial chamber with donor corneas, that if the pressure within the anterior chamber is high, the diameter of the bubble achieved is much smaller. So which kind of correlates with what we have been seeing clinically and what hypothesis we have proposed. So you can see that you got the bubble here. It's smaller in diameter. We feel the resistance. We go ahead, do a paracentesis. And now when you increase you go with the air injection, you find that you can increase the diameter of the bubble without too much of pressure being applied. That's another case. You can see that's a femtodalk we have done. Initial bubble, we felt the pressure was more. We did a paracentesis, go back into the track, and we inject air, and you can find that you can enlarge the bubble in a much more controlled manner to the desired size. At this point of time, if you again feel the pressure, you can use a Sinskey hook and release some more pressure from the side port to release some more aqueous, and then come back and inject your air. To confirm the bubble, you can do the small bubble test as described by Parthasarthi and Fontana. So you put a small air bubble in the anterior chamber, it remains in the periphery. When you deflate, the bubble comes to the center. So that indicates that your big bubble was present. The other way to look at it is that if you do a paracentesis, release the aqueous, you will find that the peripheral cornea will become soft, but the central cornea where you have the big bubble will remain firm. So if you have a cornea that's kind of completely emphysematous and you're not sure whether you achieved a big bubble or not, by using a dry merocell sponge and touching the cornea, you can get an idea whether you have the big bubble or not. And also, if you see the cornea from the side, you will see that the peripheral cornea after a paracentesis and releasing aqueous, it becomes flatter, whereas the central cornea will remain elevated like a dome. To deflate the bubble, this is a technique described by Mark Terry and Gaucher. So where you can put some viscoelastic, cohesive viscoelastic on the corneal surface, and you can pass your knife through the viscoelastic to deflate the bubble. As the air comes out through the viscoelastic, the egress of air is slower. So you don't get the risk of perforating the posterior layer is much less. I like to release my speculum to reduce the counter pressure from the posterior pressure, and I do a paracentesis, make the eye soft, and then I mark the cornea where I'm doing the paracentesis. And you can see that as you do the paracentesis here, you can see that the posterior layer does not snap back very quickly. It comes out gradually because the counter pressure is minimal. So it's important to loosen your speculum and do a paracentesis, release some fluid from the anterior chamber so that the counter pressure is minimized. So you can do a deflation much in a safer manner. Now, this is a case where we had a post-LASIK ectasia. The apex was very thin. So I did not do a debulking. So I deflated. But before I did the debulking, I marked the point where I have deflated. Because sometimes you deflate and then you do your debulking, and then you cannot find which is the point where you deflated or where you entered into the space of the type 1 big bubble. So if you mark it out, you can come back when you have to enlarge it, you can see which is the point. Some people like to inject some cohesive viscoelastic through this opening to push the posterior layer backward, and then they go ahead and they can split the residual stroma into 4 segments. You can use your regular blunt tip scissors, or you can use a scissors like this where the lower blade is slightly longer than the upper blade. It's blunt tip, and you can then divide your residual stroma into 4 quadrants, and then you can excise the stroma quadrant by quadrant. In terms of preparing the donor, you can use a dry merocell sponge to rub the peripheral edge, and you can get the decimets to peel off. Then use a tying forceps. You can hold it and you can then peel it off. You can even stain it with trypan glue, and then you can use a dry merocell sponge to rub and peel it off. And in certain cases, if you have a donor like a younger donor or where the decimets is difficult to peel off, there have been instances where people have just wiped the endothelial surface with a merocell sponge just to remove the endothelial cells, and they have put in the donor without removing the decimet, and that works equally well. In terms of suturing, you can do your preferred suturing technique, either interrupted or a combination of interrupted and rubbing and running suture. I like to do a bite of about 0.75 millimeter on the donor and about 1 millimeter on the host side, and this goes about 90% depth. And keep your chamber like normal pressure. Don't keep the eye very soft. If you keep your eye soft while you're placing this suture, what you'll end up with, you will end up with the graft becoming very flat and a post-operative hyperopic result. This is again just to show you the use of a femtosecond laser to make the cut. So the outer diameter is larger. It's about 9 millimeter. The central is about 7. And then that's the donor preparation, which is again the mushroom shape. And on the host side, you can see that the mushroom shape cut. We do a debulking, and after the debulking, we put in our cannula using the same, make the pointed dissector, make the track, inject the air. You can create the bubble. You can see that here with a single this thing, we were able to get a bubble of adequate size, so you did not require a sequential. do the bubble test, put in some viscoelastic, deflate the bubble, and then you can excise the stroma, put in your graft, and secure it with interrupted sutures. At times, you can even use the viscoelastic technique where you put in your cannula at similar about 85 to 90% depth. You have to make the eye soft, put an air bubble in the anterior chamber. The counter pressure has to be minimal as compared to air because the viscoelastic is more dense. And then when you inject air, viscoelastic, get the visco bubble, you can see the air bubble getting displaced to the periphery. And then you can open up the visco bubble, and rest of the steps are pretty much similar. If after multiple attempts you fail to get your big bubble, then in such situations, come to the periphery, make a nice deep groove. This is a small stromal pocket dissector that I designed. It's available from stores. And with this, you can make a peripheral groove using this pocket dissector. Earlier, I used to use a pair of blunt tip scissors. But the problem with the scissor is sometimes you can end up perforating posteriorly, but this is a nice device. You can do a dissection for about 180 to 270 degree, both counterclockwise and clockwise. And after you have done that, you can basically use something like the Malbrand's peeling technique. So you can see that we have gone on both sides. And once you have done that, you can use a pair of tooth forceps just to hold the tissue. And as you give sufficient pressure, you can see that the tissue is just peeling off from the posterior layer. So once you see that spontaneous peeling, you know that you are at a sufficient depth of dissection and you don't need to dissect any further. The postoperative outcome, yes, it looks great. You have good endothelial cell count. This is where I've used a combination of 8 interrupted and a running suture. You can see a good unaided vision and good minimal astigmatism. This is a femtodalc with interrupted suture. Again, at 2 months, you can see unaided vision of about 20/40, improving to 20/20 with minimal correction. For manual dissection, I like to use a planned near decimates dalc. So here, what we do is we do the 90%, 85 to 90% depth refination. That's the stromal dissector I have, again, from stores. It's a semi-sharp instrument. So I do my initial debulking, which is about 50 to 60%, come to the periphery, make a groove, and then again use the pocket forceps to make the groove, the peripheral groove. And then again, the left hand is doing most of the work here, where I'm using the left hand to stretch. And as the stromal fibers are separating, I'm using my right hand dissectors just to aid the separation of the stromal fibers just by breaking them at the posterior aspect. And with this, you can achieve a very nice uniplanar dissection, and then you put in your donor tissue and secure with sutures. That's the post-op appearance. You can see that the residual stromal bed in the immediate post-operative period is only about 30, 35 microns. And that's at the final post-op. You can see that it looks really great. Post-op medications, I like giving topical steroids, prednisolone, starting QID for a week and then taper over the next 3 weeks, after which I maintain them on fluoromethalone twice a day for the next 6 to 12 months till the sutures are in place. In pediatric cases, I tend to use full-strength prednisolone for a slightly longer period of time because these eyes react a little more because of coexisting allergic eye disease. So their FML alone may not be sufficient. I use topical antibiotics for a week. And if you're keeping the bandage contact lens for a longer duration, then you might need an antibiotic prophylaxis till the bandage contact lens is on the eye. Use copious lubricant eye drops and lubricant gel at bedtime. And the suture removal or replacement to manage astigmatism, I start that from 3 months post-operative onwards. In terms of complication, yes, if you do have perforation or perforations, you can encounter post-operative double anterior chamber, nothing to worry about. Like in this case, you can always go back and do a rebubbling with air. And in complex cases with larger perforations intraoperatively itself, we do an infi-API and sometimes use a non-expansile gas like sulfur hexafluoride to try and avoid formation of this double anterior chamber. And when you're using air or gas, watch out for pupillary block and avoid Biret-Zavalia syndrome. In conclusion, DALC should be the procedure of choice for corneal disease with healthy endothelium. Surgical techniques are evolving to ensure greater success of big bubble DALC. Intraoperative OCT is also, it's an expensive device, but if you have access to that, you can use that to try and get a track for inject or placement of the cannula. Nowadays, you have newer femtosecond laser machines, which has the integrated OCT, which can also be used to create a track for your cannula. The pre-op evaluation and surgical planning is essential. Not all cases are ideal for big bubble. So if you select your cases, you can get the big bubble more consistently. And this can help us improve outcomes in future. There was one video I did not play, so I'll just go back to that video and then I'll end my presentation. So that was a nice video of a pachy-bubble. This is done from Dr. Tanim from Brazil. So here what we do is, if you want, you can do a 8mm mark on the surface, then set the diamond knife with the micrometer at about 90% depth of the pachymetry thickness, just a millimeter ahead of the trephination mark. And then you can make a 1 or 2 millimeter cut. I use a Sinski we marked with ink to identify the cut that I have made. And then I go with the suction trefine. And this can be like a 50-60% trephination. You can debulk. Now what happens is you go to the base of the diamond knife cut that you have made. From there, you can create, because this is already at 90% depth. So you can make your track from that point, put your cannula, and then you can create your big bubble. The advantage of this technique is that with the diamond knife, you can go up to 90% depth and you make the track, and you can be more consistent for achieving the big bubble. I've done that. The only problem is that sometimes when you use the diamond knife, you set it to 90% depth, and if you press it a little bit more on the cornea, then sometimes it can go through and through because it's so sharp. So either if you keep it 80%, then it sometimes does not go as deep. So I think this also has a learning curve for which you will need some amount of practice, but this is another technique which can definitely be explored. So I think this is what I had to share about the big bubble DALK, and I hope it has been useful for all the listeners.
Thank you, Dr. Rajesh sir. It was an excellent demonstration, and you are always an inspiration for Bangladeshi corneal surgeons. So I would like to invite Dr. Soumya Murthy madam for her opinion about DALK surgery.
Thank you, Ashraf. I think that Dr. Rajesh Fogla has made it so simple. He has pretty much covered all the points. Dr. Fogla, actually, I had a question for you when you mentioned that in your adult patients, you do not use Predforte, or prednisolone full strength. But we often
I use it only for 4 weeks.
Yes,
and
exactly.
then I switch them over to fluorometholone. Yeah.
All right. So, and I'm sure Sunita and Murli, the kind of cases that we often have patients with allergy, and we do see stromal rejection in these cases. So
yeah, if they have some prior history of allergy, then obviously we'll be using steroids for a longer period of time. Sometimes I put them on fluorometholone and give them tacrolimus ointment at bedtime, which kind of works very well. Because the problem with unsupervised steroid use is that, again, then you have to keep an eye on the eye pressure and manage that. So for pediatric cases, definitely you need to use Predforte over a longer period of time, at least for the first 6 months. But in adult patients, I found that usually after the 4 weeks, they are reasonably good enough with fluorometholone. But if they had some history of allergic disease, then I would continue with Predforte for a longer duration.
So also you do a lot of cases with very advanced ectasias. And what we have seen is that there's very rapid loosening of sutures in some areas. There's a differential healing basically. So how do you handle those kind of patients?
These are the patients where I keep them on antibiotic steroid ointment for extended period of time. Often I've found that the coexisting meibomian gland dysfunction kind of makes gives rise to those sterile suture infiltrates wherever the lid is contracting usually around the inferior 180 degrees, and you will find the sutures start becoming loose or getting vascularized. So at least in those cases, maybe for a month, I keep them a nighttime mild antibiotic steroid ointment, like a chloramphenicol and dexamethasone ointment, which they apply at night. And that I find it useful.
I think that the kind of patients that we see at our institute would be fairly similar, because a lot of patients from Bangladesh do come into our center. And rather than let me say that slightly more pristine cases that you have, I think these are cases with quite advanced keratoconus, along with many of them would have ocular allergy. So I think that in these situations, I would definitely recommend using, of course, with careful monitoring of intraocular pressure, but using topical full-dose, full-strength steroids for a longer time, at least till most of the sutures are in. Sunita has a lot of experience too, and since she's here, maybe she could comment on that.
Yeah, I prefer to give prednisolone acetate, like what you said, because I feel the cases with allergy, they are much better off with a little more potent steroids. The cases which tend to have the suture loosening, I like to keep BCL for much extended period because generally we see that when the sutures become loose, they tend to erode the epithelium. So in those cases, I would really like to give BCL for a longer period. Of course, they'll be on antibiotic, but then extended periods means it can be even up to 1 month, 2 months, certain times even longer, particularly the younger patients. And Murli, if he's there around, he can add because he has some of the younger children who actually have this issue of suture losing much quicker, and then the healing can be very unpredictable. He has used hyper CL from Ion. Actually, that works very well for some of these cases because that just keeps the surface much more better and healthier, and prevent and causes healing much better compared to the regular BCL.
You can also consider giving supratarsal injection of steroids, which I usually do in my pediatric cases. I give supratarsal injection of dexamethasone at the end of surgery. And I find that that really helps in my initial post-operative period to maintain the eye. It maintains the eye very quiet. And I think the surface healing is also much better. And as you rightly pointed out, eyes where you already have pre-existing papillae under the upper eyelid from allergic eye disease, those eyes, you have to watch out for epithelial problems in the post-operative period. And you definitely keep a bandage contact lens for an extended period of time. And often in certain cases, I've even gone to the extent of using a combined DALC with amniotic membrane transplantation for eyes where I have found, because there's no point in ending up with a non-healing defect and then doing an amniotic, because by then the stroma starts, it starts losing the clarity that it had at the time of transplantation. But if you anticipate it pre and then you put an amniotic membrane, you find that you can really assist the epithelial healing and you can have a much better controlled outcome.
Thank you, sir. Dr. Murali, sir, what's your opinion here?
Yeah, I think Dr. Fogler sir is a fabulous surgeon and he covered everything, all aspects. And even in a pediatric age group, actually, we do what he said. My steroid regimen would be similar to that of penetrating keratoplasty, as Dr. Somashila was pointing out. So the risk of having the stromal resection, although it has been underreported, so that can actually have a bearing, particularly during the neuroplasticity. So my steroid regimen would be.
Yeah. In pediatric cases, I've even given oral steroids at times because I don't want to use topical steroids too frequently to minimize the topical medications I've taken, like I've given them short courses of oral prednisolone, and that has also helped control the disease process. And tacrolimus is quite useful, and I think that we are fortunate enough that in our country we do have the eye preparation which is available, and I find it quite useful. I don't know whether in Bangladesh whether you have tacrolimus preparation or not.
Yes, we have, sir, but we have in 1 minute. I would like to invite Dr. Amiruzzaman, sir, for comment. Please unmute yourself. Amiruzzaman, sir, please unmute yourself. Dr. Amiruzzaman, sir, please unmute yourself. Sir, we cannot hear you. We are coming back to you shortly. I would like to invite Dr. Adri, madam, for her comment about the steroid regimen. And we see the post-operative cataract is the most common some cases, especially we will discuss it after PK presentation. So what's your opinion about the steroid regimen?
I actually use a steroid regimen, the Predfort, for about, prednisolone acetate for about 6 months, 4 to 6 months, unless there's problems with pressure that occur. And then I switch either to fluorometholone or loteprednol. I tend to use a lot of loteprednol, and then taper from there. I'm not really that worried about cataract formation afterwards because a cataract is something that we can easily treat. In addition, if there is cataract formation, you can get a very, very nice refractive result doing cataract following PK or DALC, and then really help the patient achieve excellent vision. Here, I usually use a toric lens with additional corneal relaxing incisions. You can also just do corneal relaxing incisions to help manage any astigmatism about a year out. And so I'm not really that worried in at least adult patients following corneal transplantation if there's cataract formation. I'm much more worried about things like pressure rise. And so really paying careful attention to pressure rise, switching again to either a fluoromethalone or a loteprednol early on would be indicated, and then using any additional anti-glaucoma drops. But I think that, you have to really look, as has been pointed out by Dr. Somashila, by Dr. Rajesh. Basically, if it's a more complicated case, they're going to need a longer steroid, stronger steroid regimen. If it's a more simple case, then it's easy to switch them early on. But one of the main things is really managing the pressure.
Thank you, madam. I would like to invite Dr. Amiruzzaman sir for his comment. Sir, we cannot hear you.
Are you hearing?
Yeah, we can hear you now.
Yeah. Congratulations, sirs, for excellent presentation regarding DAL, and other speaker also done very, very good presentation. It is actually shown us that we are learned many more from these presentations. Regarding the DAL, actually we are doing DAL. We are watching the YouTube videos from various surgeons, and we are actually prefer DALK in case of the keratoconus, but in case of advanced keratoconus, where there is a hydrous formation, we are doing the manual DALK. And in that case, result also good. Here my question, actually, it is not question that the graft size, donor and recipient, say about 8.25 we are using, but our sir, Rajesh Fogla, probably he use same size, or is there in disparity? Can explain, sir?
For ectatic disorders, we try and use the same size. But for non-ectatic disorders, we can use a disparity of about 0.5. If you are using the manual Trifine, if you're using the femtosecond laser, the disparity is only about 0.1 millimeter, because the femtosecond laser is so precise. And if you make even a 0.25 millimeter disparity, you will find that the graft and the donor don't really fit together because of the sizing issues. But for ectatic disorders, I use same size, and I find that post-operatively, I do get a little bit of hyperopia in the initial immediate post-operative period. But once you start removing the suture, they become much closer to emetropia. If you oversize, you may get initially emetropia, but when you do suture removal, they all end up with 3 to 4 diopters of myopia. That's what, in my surgical technique, it also depends on how you suture. If you suture pretty tight, then maybe oversizing, it's much better for you. So this is something that each surgeon has a slight preference over what sizing they use.
Sir, when we are using the optical PK suturing, it is 16 suture we are prefer. But in case of DALK, we are using more. Is it right, sir?
No, if I'm using, it depends on the diameter of the graft. If I'm using 8.5 with the interrupted sutures, I usually use 16. But if I'm using a combination of interrupted and running, then it's 8 interrupted and a 16 by running. So, so then what happens is post-operatively, if I see astigmatism, the interrupted sutures come out first. So the running suture still remains for as long as possible. But if I use a 9 millimeter graft, then maybe the interrupted would be, instead of 16, I may prefer to put 24 because the circumference is much larger. And what happens is if you put lesser number of sutures, and if you have some unpredictable astigmatism and you want to pull out 1 or 2 sutures, then sometimes you have to wait longer because you don't have sufficient number of sutures to support the adjacent cornea that you can't pull out the suture. So that's where I think you need to titrate your suturing technique depending on what diameter of the graft.
Thank you very much, sir.
Suture removal, actually, we follow that after 12 months, we try to remove the suture after pentacam evaluation or topography evaluation. So we are following that.
Yes, I remove sutures sometimes in the early post-op as well, because if I see my patient at 1 month and I find that he has 9 diopters of astigmatism, and I find the suture is tight in one particular axis, I will replace that suture. That means I'm not going to just remove the suture and leave it like that, because at that point, my graft host junction is not yet healed. And if I just remove the sutures, I will get microdehiscence of the graft host junction, which will later on give an abnormal outcome when the remaining sutures are removed. So I will go ahead, replace the tight suture with a normal tension suture at 1 month, rather than waiting for 1 year, because by then the graft host junction is completely healed. And even if you remove the suture, you will not get the kind of optimal curvature that you desire.
Thank you, sir.
Thank you very much, sir. I'm pretty sure we have lots of questions about this. We will discuss it in the question answer session. Now I would like to invite Dr. Muralidhar Ramappa, sir. He will be talking about the penetrating keratoplasty in the era of lamellar surgery, a very interesting talk. Sir, would you please share your screen?
Dr. Ashraf, can you see my slides?
No,
Can
sir,
you see
it's
my
not.
slides? Okay, okay.
No, sir. Please share your screen, sir.
Sure.
Yes, sir.
Yeah.
It's visible now.
Yeah. At outset, I would like to thank Bangladesh Eye Hospital and Ashraful for this opportunity. So I've been asked to talk on a penetrating keratoplasty. So we'll try, explain, the relevance of, penetrating keratoplasty in the background of, we have a lamellar surgeries which is taking a precedence world over, and would touch upon a certain basic aspect of penetrating keratoplasty and a special scenario, and both intra and post-operative challenges, particularly when we do a large therapeutic grafts. And if time permits, few interesting case scenarios as well. Although, as I said, the most surgeons, worldwide, 3/4 of them are actually doing lamellar surgeries, but penetrating keratoplasty still have a role in our surgeon's armamentarium. And the large proportionate of pan-corneal diseases, as Rajesh Fogla alluded, there are certain cases wherein a DALK is not feasible, so where PK has to be the way to go. If you look at, there are various indications, like endothelial dystrophy may have a pre-existing keratoconus or ectasia, full thickness scar, post-eye drops keratoconus. And previously, 20, 30 years ago, PKs have been done with a severe astigmatism, graft post ectasia, and cases which had a, multiple post-glaucoma vitreoretinal surgeries, wherein you have a large iris, the sector iris defect, and you have a communicating chamber, and you have a AGV or one of the tube in place may not be very ideal for a DMIC or a DSEC. And of course, in a troubleshooting, when following a post-DALK or a post-DSEC, if somebody develops an interface infection, which is, recalcitrant, we may have to go for, again, therapeutic grafts in those cases as well. And therapeutic primarily, in a non-responsive microbial keratitis and those which have corneal ulcers, which are perforated or impending perforation, and primarily severe form of fungal as well as a parasitic infection actually merits the penetrating keratoplasty. And it still has an important role. And the PK has its own set of challenges. One of the biggest advantage of, why the lamellar surgeries are becoming more popular is that one of the biggest advantage being they have a much better graft post, the tectonic stability, and they eliminate all kind of a suture related aspect. And third most important is that, the allograft rejection is a much more less common, more reversible, even if somebody does allograft rejection, unlike in a traditional penetrating keratoplasty. So one of the perceived advantage of penetrating keratoplasty, you can actually use a less stringent donor corneal grading compared to the lamellar surgery. Even in those cases which are above 75, even having a 200 endothelial, 2000 endothelial count can be easily used for a penetrating keratoplasty. As Dr. Fogla pointed out, the femto may have actually, the immense benefits. Particularly, it helps you, having a precision cut. You can actually go and tailor, your bed various configurations. So this may actually helps in negating the, post-operative astigmatism. also better wound apposition, and maybe we can actually plan a suture removal much earlier. Now, with this background, so we have basically two important aspects here. You have optical, wherein you want to restore the visual axis. This is a very elective procedure, very controlled scenario. You would typically use between 7.75 to 8.5 millimeters, depending on the overall corneal diameter. Whereas a therapeutic graft, it is mainly either for establishing a diagnosis or a eye salvaging procedure. And you have a gamut of conditions wherein you may have to do a penetrating keratoplasty. And if you look at particularly Southeast Asian countries, although I don't have actual numbers from the Bangladesh, and these numbers are very staggering. India alone every year have over 8 lakh new cases of corneal ulcers, and nearly the more than one third of them actually eventually end up having a corneal transplantation. And you have a plethora of cases have at times severe mycotic infections, perforated ulcers, and the last one is one of the non-resolving parasitic infection. And these are the setup instrument. As Ashrafullah was asking me to give an entire detail about the instrumentation and spend a little more time on the technicality. It's very, very important to have a preoperative preparation and preempt any intra and post-operative complication one may anticipate in these cases that would actually help in achieving a much better outcome. As Dr. Fogla said, I would actually prefer, instead of a freehand, I don't have any financial disclosure. The vacuum trifines tend to be, much more preferred. They're much more precise, and they will help you, let not only achieves a better centration and would also help you get, 90% initial depth. So that actually, simplifies your entire surgical steps. This is very important to have a self-retaining speculum which doesn't impinge upon the globe, and therefore it doesn't directly translate into rise in intraocular pressure. And wherever it is feasible, I would recommend using a Fleringa ring. Use it very, very judiciously. And this is one of the scenario wherein to video to show not to use a wide speculum. So that actually inadvertently rises intraocular pressure and it complicates. And in almost pediatric cases, we may have to use a Fleringa ring. This is how we actually fix a Fleringa ring. And these are the setups, some of the metallic, the traditional trifines which been used for the last century with the various modifications. And as I said, the most younger surgeon actually preferring the newer variant that helps you much controlled refination. And it also gives you a big advantage at leaving behind a thin, the ledge. I'll come to the surgical video. And this also eliminate, certain times we may end up having a decentered or eccentric punching. Thereby, the donor tissue, you may end up having stem cells. The peripheral cornea is much more immunologically reactive, so that can actually makes not only it introduce additional astigmatism, it can also make your graft high risk. So this is one of the, the diagram actually illustrating, one has to avoid, decentered punching. Although it may give a higher endothelium, but it also biggest disadvantage is being it includes the donor limbus that is undesirable, and also the astigmatic component, because the peripheral cornea not only thick and it is also flatter. So once you actually fix a Fleringa ring, this is how actually we get the centration. Centration, one of the best way to get the centration is by guesstimate method. And I like to leave the very thin uniform ledge, about 10% of the stromal depth. That not only helps you to get a watertight bed, it also minimizes the risk of a pus formation. And you don't have to end up, giving a very tight sutures. It will give a very secure watertight closure, thereby actually minimizes the amount of astigmatism. It's very, very important to use a very good pair of needle holder, as Dr. Fogla pointing out. It should be very atraumatic. And, this is how, we catch. So even a tip of the 10 nylon needle, if it goes through and through the donor tissue, it takes away nearly 180 cells. Just imagine if I inadvertently go and pick up the entire donor tissue, it damages a significant amount of endothelium. It's very, very important to handle these tissues very carefully. And these sutures have been designed in such a way that, these are a polycurve. They not only give a short card length, it helps you to take a very deeper bite, at same time shorter bite. So that is a more desirable. You need to have a deeper bite and a shorter length. Thereby you have a less amount of flattening effect and it minimizes the amount of astigmatism. This is an ideal way. You need to have on either side, your desmet to desmet opposition, and you have a 90% thickness, okay? And your knot can be either, buried on the host or, the graft. It's depending on, surgeon's preference. Again, a cartoon C actually shows this is how, your suture has to be under just subepithelial so that it doesn't actually expose us. So I always tend to, oppose my desmets to desmets opposition between the graft and host. So that will avoid, the posterior lambda defect, and you'll have a more predictable outcome. So these are the certain complications we may encounter during a penetrating keratoplasty. And these are these are the most complications are technical. If we have, meticulously plan our surgical thing by actually anticipating which are the cases which are likely to develop complication, one can easily minimize this complication both intraoperatively and as well as postoperatively. This was about 11-year-old child. This was, I did about 13 years ago, this surgery. Then we used to do a penetrating keratoplasty for even a congenital hereditary endothelial dystrophy. I'm just measuring, so I tend to take a little larger graft in an endothelial dystrophy. The reason is you don't have a peripheral endothelium. So I must have taken 8.8 and 8.5 millimeter in this particular case, so that I end up, giving, 25% more endothelium than a traditional graft. So you can use one of the radial keratotomy. It's very, very important to inspect this metal because these are reused. Sometimes they're extremely blunt and they are a bit unpredictable. One has to be really very, very judicious and careful the amount of pressure you exert. And invariably in this, these instruments either be undercut or over-refined. So it is desirable to have an undercut, re-examine, see how far you have gone. This particular whole, the recipient bed may be having 1,000 microns. So I must have gone about 6 to 8 turns here. And as I mentioned, it's very, very important to have a thin, uniform ledge all around that helps you give you very good water tightness. And if you have an excessive ledge, you can actually always use a Vanna's scissor and to trim it. So if it compresses the donor tissue, it may contribute to additional astigmatism. And make sure your ledge is uniform all around. Either you have a ledge or a no ledge. I typically use a 0.5 millimeter disparity when we use a manual or a metallic refines. And the most important is the first four cardinal sutures. And throughout procedure, make sure your anterior chamber is well maintained. And your globe should never be collapsed. And also ensure when you are completing your cardinal suture, you don't have your speculum impinging on the globe. You don't have any undue stress. So this is how you can. I tend to bury my knots under the host side because while removing it's technically much simpler and easier for me. So this particular video actually highlights the importance of the Fleringa ring. Make sure Fleringa ring is about 2 to 3 millimeter bigger than, so it helps you some of the inadvertent complication intraoperatively. Again, as I said, the vacuum refines are helps you be much more accurate. You can consistently achieve, 90% depth. These are some of my old videos. It's a while since I made a presentation on a penetrating keratoplasty, and I was just keeping a very thin uniform ledge all around. And in this particular video, what I wanted to highlight is that, while suturing, I was making every effort to keep injecting, make sure your angle recess is well formed. Particularly in a pediatric age group, you have a lot of fibrin which keep, accumulating. And there should not be any untoward, manipulations. And here I was burying to the host site, and the rest all steps are simpler, easier. If we follow systematically, we don't end up injuring uveal tissue, lens. And coming to some of the therapeutic options, these are the certain indications. Those are all recalcitrant, and sometimes they may be refractory to the treatment, maybe impending perforation, or maybe they're threatening, involving the limbus as well as a sclera, or even a posterior segment involvement actually merits a intervention. So very important to assess the size, location, depth, what are all the other structures actually involved in the anterior segment that helps us tailoring our surgical intervention much better. It's very important here in those cases wherein you can't actually assess the posterior segment, make sure infection is confined to the anterior segment, or we may have to co-manage along with the vitreoretinal surgeon. And I prefer to have a general anesthesia, particularly when I do a large therapeutic graft. It's much easier. You can actually, avoid many intraoperative complication. And even these patients, because they've been pouring a lot of toxic medication on the surface, their pain threshold is extremely low. Therefore, these cases actually merits a general anesthesia. These are the certain case-to-case surgical steps. It's very important to leave about at least a millimeter of a clear cornea all around. That at least you are taking care macroscopic lesions. Although I'm not sure about the microscopic lesions, so I'm just helps me. I'm trying to debulk as much as in this particular instance is a fungal keratitis. So very important to use a very sharp instrument. In a soft globe, even your sharpest instrument looks blunt. And so each rotation has to be carefully done to avoid inadvertent lens injury. You can actually see and so I would recommend here the negative Trendelenburg position, meaning the head end elevation, hyperbaric accessionation, constantly having a dialogue with your anesthetist actually helps. You can also give a preoperatively mannitol that helps you make your eyeball vitreous shrink, and you can actually avoid a posterior upthrust. This is again quite a very large graft done by one of my fellow. And rest all steps are similar to what I have shown it to the penetrating keratoplasty. And what should be the size? Up to 10 millimeter, we would do about 0.5 millimeter disparity. Beyond 10 millimeter, 1 mm disparity between the graft and host. That not only helps in maintaining the very deep anterior chamber, and that also give me some opportunity to minimize the risk of glaucoma in these cases. Because when you do a large graft, limbus to limbus, we may be excising the angle structures and causing a lot of peripheral synechia formation. Therefore, it's very important to have that additional a millimeter difference between the graft and host. So also, there are two schools of thought. If your iris is extremely inflamed, as in this particular case, and it bleeds a lot, I would recommend, not to do a peripheral iridectomy. Even, it forms a lot of fibrinous layer, and whatever peripheral iridectomy you end up doing, either it bleeds or a fibrinous, invariably, it obscure your PI opening. It doesn't serve any purpose. And even if it is, the very, visually significant cataract, for me, it is absolute contraindication. I do not remove or plan a cataract surgery at the time of therapeutic grafting. So all the pupillary membranes, everything can be precisely removed. You need to inspect iris for any residual infection. And also, sometimes even the infiltrate may be there in the ledge. It's very, very important to inspect the ledge and excise the entire ledge in case you find any infiltrate. And sometimes, the graft size can be actually known by, if you can actually wash in this particular instance, you are debulking significant amount of, dense carpet like, the lesions which are covering the back part of the cornea. So this gives a more clarity what should be your ideal, refined size. So although it was looking, in the coaxial illumination, we may not actually know the exact, the location of the corneal infiltrate. So once you evacuate your anterior chamber, then that helps you to having a much smaller graft than what it is appearing. So the smaller grafts are, much desirable than, doing a 10 or a 12 millimeters sclerokeratoplasty. Although it may be successful, in eradicating infection, but in terms of functional viability, they generally have a poor outcome in a long run. So the fellow is doing here, I think 2 or 3 peripheral iridectomy, although I don't prefer such a iridectomy. And as I said, so one has to really inspect any iris lesions, lesions in the angles, lesions in the ledge that generally overlooked. That's one of the important reasons for the recurrence in the early post-operative period, that foci should be eliminated. And let's see, what are the steps we can actually take to avoid, the recurrence. If you can look at, this is in straddling up to the limbus, involving the limbus inferiorly. And this is a ledge which is having an infiltrate. So excising the entire infiltrate again minimizes the risk of, the recurrence when you particularly start steroids after 2 weeks of a therapeutic grafting. And our steps have to be very gentle, delicate. Make sure we don't, end up, injuring the lens, iris. And it's very, very important to have a very, very fine instrument while performing these cases. And one of the most important thing, although, we prepare our donor tissue even before, opening up the recipient bed in a certain scenario wherein you have a pre-existing large perforation where you hand fashion. So since, you don't know what is the actual size of the peg which you are going to create on the recipient bed. So it's very, very important to, prepare the donor tissue in such an instance after completely, measuring what is the defect size you end up, making in. So that actually, minimizes the risk of having a graft dose disparity. And in all this, one of the thing which I wanted to show in this particular last clipping is that, at least try to preserve, the 2 quadrant of the limbus and 2 quadrant of at least angle structure that helps in, maintaining the intraocular pressure. And also it helps in, maintaining the surface homeostasis. Otherwise, you end up having a post-operatively epithelial defect and end up a conjunctivalization that can be a poor prognosticating marker. Ashraf, let me know if I'm exceeding my time. I'm bringing a lot of surgical. This is again one of the perforated herpetic ulcer. Normally, we don't operate, the herpes when the disease is very active. Only in cases where even a tissue adhesive doesn't help. So those are the instances. And this particular case where lens was extruded earlier and surgeon is doing a vitrectomy. And this is a large kind of a pseudocornea, almost, kind of forming an anterior staphyloма. And here you have to hand fashion your trifine. And unless you complete, the peg, you don't know the actual size. Again, deliberate effort has been made. At least, we are preserving 2 quadrants of the limbus as well as angle structure. so as to maintain the post-operatively healthy corneal surface and also the intraocular pressure. So I'm just skipping certain steps. I don't know, for unknown reason here, the surgeon end up removing the lens, although I don't prefer. And this can be eliminated by giving a preoperative mannitol and using something, those other than, wire speculum. So then can actually helps you minimize that complication. And cases which have a perforation, I always recommend you to seal that perforation with a tissue adhesive intraoperatively, try to reform and try to simulate, as if it is a normal eye. So that will give you very controlled. Instead of refining a soft eye, if you have a very firm eye, it's easy to refine, easy to make tissue dissection much more reliable, and you can easily maintain a good, uniform lids in these cases, and excising whatever the pupillary membranes. And surgeon is removing here one of the mature cataract. Even if we have to remove the cataract, never attempt an intraocular lens when particularly you suspect that your etiology is infective. And you can also inspect, do the indirect ophthalmoscopic examination at the end of surgery. If you find your glow is unhealthy, if you have any suspecting the posterior segment issues, it can be co-managed at the same time rather than postponing to the next day. So that does really influence the post-operative outcome. Some of these cases can have a complicated cataract because of a posterior segment involvement. Particularly important to recognize, the sequestered anterior endophthalmitis. So even after removing cataract, you can actually see in this particular instance, the glow is unhealthy. So something it is, not very usual. So this actually, hit your red flags and make sure, you get the retina surgeon and inspect here. As I said, I do not remove even if there is a significant cataract, because this serve as a biological barrier for infection to getting into the posterior segment. The problem is that most often when we actually inadvertently remove the lens, we end up even breaching PC, end up doing a vitrectomy and converting into one single chamber that is highly undesirable. If it is a fungus, once fungus actually gets into the vitreous chamber, and it is a nightmare. So any penetrating keratoplasty, when you combine surgery, do a vitrectomy, your graft survival actually significantly falls by 50% at least. So therefore, these are all the avoidable steps. And also, having done a vitrectomy, your globe tend to collapse. So end up having a trabeculum short collapse, and it in turn actually complicates your glaucoma management. So there are other abnormalities in the late adnexa. You have a dry eye. This has to be, and so mind you, these grafts for the next 6 to 9 months, they are anesthetic. They're very vulnerable for developing epithelial issues, prone for infection, recurrences, sterile melt. So this has to be addressed. So in the cases where it merits, I would do, the tarsorrhaphy. If the patient have no cosmetic issues, or in cases, we can also do a punctal occlusion to maintain the good surface post-operatively. So particularly these strategies are recommended when you do a large graft, when you have a more than 1 millimeter disparity. Your corneal contour is a much steeper, so your resurfacing would be very poor, and you have a poor limbus when you involve more than 3 quadrants, and particularly neurotropic cornea. And if somebody had a previously PED or surface issues because of a toxic medication and so on. So although this graft actually looks pretty good, done by one of my senior fellow, but had a large desmet detachment. So this can be easily tackled in the intra or post-operatively, as Dr. Fogla was pointing out, using some of the newer technology. Inbuilt intraoperative OCT helps you picking up these complications and help you manage immediately some of this post-operative fibrinous reaction. And once you have something like a hemorrhagic, so it mixes with everything and have a DM detachment. So these are the cases very tricky. Even a desmetopexy may not work in such an instances. So seemingly very good case, doing very well. And these are the certain complication. This video actually demonstrate, the risk of lens expulsion, and one has to preempt, as I said. There are a variety of risk factor, and people particularly who had expulsion in other eye is also a very important risk factor. So these are the ocular conditions as well as a systemic condition one has to see preoperatively, preempt, and take additional steps and precautions to minimize this catastrophic complication. And these are the steps, both intra and preoperatively, one can actually. And the glaucoma is an important thing, particularly when you do a bigger graft, a larger and lengthier sutures, more than 24 sutures. Okay, these are the things which have to be taken care. And this was a case needed a large sclerokeratoplasty. This gentleman, inadvertently used a dexamethasone for a fungal keratitis, referred from Rajasthan. And post-operatively, look at this one. So the local treating, doctor, he said, there is a recurrence. This gentleman has to flew back. Actually, he had a hyperimmune rejection. If you can look at this particular case, look at the OCT. The graft is almost 1,000 microns. So what I did immediately, it was a 13 days since therapeutic graft, hospitalized him, started IVMP, and within a few days, the graft cleared, and he maintained a good vision. Thereafter, I did a DMIC in this particular case, along with a cataract surgery, having a good outcome. And these are the certain cases where late management and a residual infection can lead to very bad recurrence and end up having a poor outcome. So if you look at the most penetrating keratoplasty, they have a poor survival. And what comes rescue is here that, you can actually, preemptively manage these cases by subjecting them for endothelial keratoplasty can actually helps them to give us some decent visual outcome. Otherwise, by the end of 1 year, most of these therapeutic grafts succumbs, not only due to, we use sometimes, the substandard quality tissue, and sometimes, it's a larger graft and pre-existing inflammation, glaucoma makes the graft survival much, less suboptimal in these cases. So even a well-performed therapeutic keratoplasty can have a good outcome. So every case is a unique and need to customize your approach and learn, reinvent as you go, and a meticulous, post-op follow-up, and the steroid regimen is a key in prolonging the graft survival in these cases. Thank you for this opportunity. If there are any questions, I'll be happy to answer.
Thank you very much. Thank you, Muralidhar sir, for excellent demonstration. It was very elaborative and very helpful. Now I would like to invite Dr. Sarwar Alam sir for his comment. Sir, please unmute yourself.
Thank you, Bangladesh Eye Hospital and Dr. Ashraf for organizing this beautiful webinar, and it will help our doctors a lot. And there is little scope of comments after the masterly presentation of different masters on cornea. We must say that we are a bit behind in the surgical side where cornea is needed, Bangladesh. One of the main reasons that we are solely dependent on exported cornea. So we cannot experiment, we cannot go beyond a certain limit. Why I'm telling this? Because in other sectors, our doctors are doing excellent in cornea, in retina, pediatric, oculoplastic, glaucoma, and phaco. They are in the world-class surgery they are doing. But in this aspect, we are lagging behind only for the tissue. But what tissue we are getting, gradually out of this, our doctors are went long back into the deep anterolamellar keratoplasty. Now they are going to dissect DMEC. In the parentetic keratoplasty, India and Bangladesh scenario is almost same. We are having a lots of patients who are needing therapeutic and tectonic keratoplasty. And this therapeutic and tectonic thing is so needed that many times with one cornea, with some of the leftover tissue, though it might not sound so healthy, we are doing patch graft in another patient also for saving the eyes. And one of the problem in our patients is follow-up, because they have their mind that our surgery is done, and so we might be giving medicine for 1 month or maximum 2 months. Then they are not coming for follow-up and other things. So the sometimes results are not so good, the rejection failure. As for example, in the last week, I've seen one of my cases has not seen during the COVID period and has not given single medicine, and there was injectable glaucoma, and there is dehiscence and ectasia of every side. And so that thing failed. And especially what Dr. Muralidhar has said, the more problematic is the pediatric cases, because they are difficult to examine. The parents are struggling, and after struggling for some time, they abandon the medicine, because young child, they don't open their eyes, and after struggling for 1 month or something there. And also when they are loose sutures, parents are ignoring, and when they're coming, they're having some infiltration at the suture site. So we are fighting with those things. And about the other lamellar keratoplasties, DLK, initially we tried with the simple manual dissection. And later on, we are trying with the big bubble. Sometimes we are failing, but gradually the results are improving. And very recently, as Rashid has said, we have started demake, dissect. But one of the main constant again is the tissue. In many cases, we need two tissue in hand for tackling a surgery, but we don't have that luxury. So thank you very much. There are much time, and there are many questions also to be answered by the panelists, experienced surgeons. So I'm concluding my remarks.
Thank you, sir. Thank you, sir. I would like to invite Dr. Adri Madam for her comment. On 2018, I had opportunity to do keratoplasty under her direct supervision. She is an excellent mentor and teacher. Dr. Adri Madam, please.
Great, thank you so much. You know, I always learn from my great colleague and friend, Dr. Murli, and really nice points, especially for management of some of these more complex cases. You know, there's so much blindness from infectious keratitis. And I think that the teaching points, especially that if you don't have to remove the cataract, I think that that's such a key teaching point, then don't. You want to leave the additional barrier. Also about the AC washout, another really, really important teaching point for attendees is that sometimes things are worse than they appear, but sometimes they may not be as bad. And to be flexible, I think, I'm trying to remember the word, is it jugar? You know, where you need to be flexible. It's a Hindi word. I'm probably saying it wrong. I think Dr. Rajesh taught me this one. And you just need to really go with the flow and always be looking at being flexible in terms of your technique. And so really appreciate the comprehensive teaching points there.
Thank you, madam. Thank you, ma'am. So now we are moving to the question and answer session, though we are running out of our time. But one question to Dr. Rajesh sir, that when you prefer to do the interrupted suture or when the continuous suture?
If I have a patient who is not going to be under my follow-up, then it's always interrupted, because it becomes easier for the follow-up surgeon, who may not be a trained cornea specialist, to be able to remove any broken suture rather than have a running suture and, you know, they kind of remove it partially and then patient has to rush back. Otherwise, if I have a patient under my follow-up, I prefer a combination of interrupted and running, because a running suture I can adjust to kind of minimize the astigmatism, and it kind of works quite well in my hands. If I have a vascularized cornea where I've done a DALC, like in post-chemical injury or something, then obviously it's always interrupted suture. Even in pediatric cases also, interrupted sutures are better because the sutures tend to become loose much faster. So you would not want to have a running suture where it in one quadrant it has become loose and then you have to go back and manage that as well.
Thank you, sir. And to Muralidhar, sir, sometime after PKP, we see the mydriasis. So the pupil, dilating pupil is very difficult to come back in the normal size. So what's the suggestion on that?
Sorry, can you come again, your question, the micro?
After PKP, we see the patients has the mydriasis and the dilating
Okay.
pupil is not come back to the normal size. So what's your suggestion on that?
I think, perhaps it might have happened intraoperatively, maybe a pupillary insult, or sometimes Uret's javelia, I believe behind an ear, the pupil or iris has suffered ischemic insult. So those are all the primary two important reasons. But that apart, I've never had any pupillary issues. Dr. Rajesh, you have any time?
I think one point that I would like to add is whenever I do penetrating keratoplasty in these kind of scenarios, I always like to take lid sutures, because you put in a speculum, but at some point of time you want to minimize the pressure on the globe to reduce the upthrust. If you have lid sutures, you can remove the speculum and still do your surgery, and that you can find that the iris and the lens, which kind of trying to come up, it kind of goes down. And I don't hesitate to do a single port vitrectomy to sometimes prevent a spontaneous expulsion of the lens, because that will be much worse to manage rather than make a single port, just do a little bit of core vitrectomy, everything kind of settles down, and it allows you to put in your graft and put an air bubble and maintain the chamber very well. You can avoid peripheral synechiae, postoperative glaucoma. Otherwise, with that upthrust, you can secure a graft, but then you have a flat AC, raised pressure, and sometimes that is futile. You may have succeeded in putting on a graft, but postoperative, if you see the patient has uncontrolled pressures, and then you put in a tube, and finally optically you cannot rehabilitate the patient at any point of time. So I think this is where some amount of planning needs to be done, and doing a single port core vitrectomy is I think it's quite helpful in these kind of scenarios.
Great
I would like to have the opinion from others as to what they feel.
Right. No, great point actually. Even a mannitol may not work in an inflamed eye, so where you have so much of uveal inflammation. So mannitol, even if you give 30 to 45 minutes a prior, so sometimes they may not achieve efficient IOP control. I think that point is a great. I missed out, the lid suture. That's my professor always used to tell this. This is really one of the best strategy to avoid impinging on the globe and using a secondary rise in pressure.
And also to prevent the bleeding, putting in brimonidine drops before you start surgery is also quite helpful. And I like to cut Merocel sponge into smaller pieces. And let's say when you're trephining or you're doing anything and it starts to bleed, just put a piece of sponge there rather than repeatedly irrigating out. And you find that by placing the bits of sponge there, it absorbs the blood and it stops the bleeding. So, that works much better rather than repeatedly trying to flush that area. Same thing I do if I have a bleeding from the iris as well. I will take a piece of that Merocel sponge, leave it there, and you find that it soaks up the blood and it arrests the bleeding, allowing you to visualize better and complete your surgery rather than completely irrigating it and having persistent bleeding. So that again is quite helpful, saves time and allows you to complete your surgery first. Even when you're placing suture, because these are very large grafts, and you take one bite of the suture and the suture tract starts to bleed and all that blood will go into your graft or junction, sometimes go into the eye. So if you put that small piece of sponge there, it keeps absorbing the blood and allows you to continue with your surgery without messing up your entire surgical field.
Great point.
Thank you, sir. I think Dr. Rashid, the one to ask question. Dr. Rashid, please ask.
Hello, sir. My question to Rajesh, sir. So in my few DELC patients, there are some DM fold in the periphery. So it is due to the disparity of the size, or what is the cause actually?
Yes, if you have a very ectatic cornea to begin with and you use the same size graft, so obviously there will be folds, and the objective is at the end of surgery, you can manipulate the posterior layer through your graft or junction to kind of stretch the posterior layer so the folds come out of the visual axis. So if they remain in the periphery, they don't have any impact on the vision.
Yes,
but
absolutely.
Try to avoid having those folds running through the visual axis.
Thank you, sir.
Thank you.
Thank you, sir. Dr. Amiruzzaman, sir. Dr. Amiruzzaman is doing the highest number of transplantation in Bangladesh right now. Dr. Amiruzzaman, sir. Sir, please unmute yourself. Dr. Amiruzaman sir, please, yes.
Thank you. Thank you. Actually, excellent presentation. We will learn more. I am doing DLK. I'm doing therapeutic PK, optical PK, many. Actually, imported cornea from USA and Nepal. So my experience regarding the therapeutic PK, we are not actually doing therapeutic PK. During the perforation, we use the sclerocorneal button, small button, and use the intracameral amphotericin or voriconazole, make the field fertile. And then in pool stage, we go for the optical PK. And it is the common scenario. Sometimes we are using the intracameral amphotericin voriconazole along with deep debulking of the ulcer and to make the conjunctival hood flap surgery. Though it is not popular in your scenario, but in our setting, actually, we try where there is no cornea is available. And in DLK, SAR says that advanced cases, when the cornea is thin like 200 micron, in that cases, big bubble causes, there is some perforation, we fail. Sir, is there any suggestion regarding in that cases?
No, in my indications, I had mentioned that if you have the apex, which is thinner than 200 to 250 microns, in those cases, a manual near decimal dissection is much better. Because if you try to inject air, you're going to have a perforation or you're going to have a type 2 bubble. So basically, you will have an undesirable event during the surgery. So in such cases, doing a planned near decimal dissection, a manual DALC will give you much better outcome than trying to do a big bubble.
Thank you, sir.
Thank you, sir. And one thing, there is a big debate that in case of PKP, we do cataract or not. Sir, Muraldhar sir said that doing PKP alone and then do the cataract. But sometimes we need to do the triple therapy together. So what's your suggestion that should we do the significant cataract cases we leave alone first?
That again, it's a clinical decision you need to make, because if the cataract is visually significant, obviously in our scenario also, nobody wants to undergo 2 surgeries. People want a single surgery. So we can explain to the patient that if you do a combined surgery where you do a corneal transplant and a cataract surgery, lens implantation, your visual outcome is going to be, less, you will have to wear glasses and unaided vision is not going to be perfect. Whereas if you do a stage surgery where you do the cornea transplantation first, wait for the suture removal, let the curvature stabilize, and then do a cataract surgery, the patient can achieve much better refractive outcome. That means his unaided vision would be better than what he would have had doing both the surgeries together.
Thank you, sir. And there is another question from the participant that do you prefer to remove iris in recurrent cases of graft males or re-PKP?
No, unless if the iris is normal, then there is no need for removal. But if the iris is plastered to the cornea and you cannot separate it and then you have to do your trephination, then whatever iris is plastered to the cornea, sometimes you will excise. Otherwise, you want to retain the iris because that helps keep the intraocular lens in place. If you remove a lot of iris, sometimes you'll find that the intraocular lens will start jumping out, so it won't be stable, and then you will have difficulty during the surgery. The other thing that I do is if I find a patient who already has a lens in the eye and a large iris defect, and I have to do a keratoplasty, sometimes I will take my 10-0 Prolene, the straight needle, and I will pass it from limbus from one side to the other. I will pass 2 of them. And this kind of keeps the lens back in place when I'm trephining my cornea, so that when I have an open globe, I don't have my IOL trying to jump out of the eye. These 2 straight needles going from limbus to limbus kind of keeps that IOL in place and preventing it from coming out. Otherwise you will have the PC IOL coming out and you will have to then manage it in a different way. So this is certain scenarios we want to keep that posterior layer intact. We try and do that, especially where the iris cannot be repaired.
Thank you, sir.
Other biggest disadvantage of removing iris is that you leave behind all around a small stump. It closes, it zips around the angle, it produces intractable glaucoma. We have to be extremely careful before making a decision to excise or upsize the whole of the iris or a part of the iris. If you excise part of it, remaining will free floating will invariably come and stuck on the back part of the graft. It will form an extensive synechium. So both the scenarios are undesirable. And my threshold to, as Dr. Fogla said, I invariably, if there is a pupillary distortion, the pupil sphincter is damaged, I don't hesitate to go and do a pupilloplasty. That's, not only it keeps the, IOL everything in place, and it also minimizes the risk of pus formation because there is no redundancy in the iris per se. Dr. Somashila, do you have any difference in opinion?
No, I agree with you. I had just a couple of points I wanted to make is that because
Please.
when we're discussing PK, but or I'm sure everybody understands that PK for an optical indication is a totally different kind of surgery altogether. And therapeutic PK is again a totally different kind of surgery altogether. So ideally they're literally two different surgeries, so to speak. So the way in which you approach a therapeutic indication PK, and very often we have very large extent of the ulcer, as Murli mentioned, and he showed you that very advanced cases. Whereas in the case of optical PK, it's clean, you can have a smaller graft, and things are much more controlled. So for therapeutic PK, sometimes I think the question pertains to when you have a melt of the cornea, and maybe even the initial keratoplasty gets infected or something like that, and when the patient comes back. So the only instance that where you would actually have to sacrifice the iris would be if it's already stuck or if it's already out in the perforation, or if it's extensively invaded by, say, it's fungal keratitis, and sometimes you have a lot of exudates, and you know that there can be fungal filaments, but still you must try to retain the iris, as Murli mentioned, for the reasons that he mentioned. More and more, we've been shifting to doing the single port vitrectomy, which is kind of like a blind vitrectomy. It's pars plana. So you just put in the sutureless, the 25 gauge vitrector, and do a very short limited vitrectomy. If you have retina colleagues, they can do it for you. But that makes the surgery for therapeutic PK very, very predictable, and you don't have the lens jumping out, as Rajesh mentioned and as Dr. Murli mentioned. So it's very important to retain the lens in these cases. So I think it's a huge topic that Murli covered, and there are lots of points, I'm sure. And we're all available. Dr. Ashraful has been with us, and all of you can visit us if it's possible. Later, when people start meeting physically, that's when you come and visit us, not now. And we'd be happy to really help and get some collaboration going. Thank you.
Thank you very much, madam. We are now 150 minutes, that's 2.5 hours of this webinar. So any of our participants, do you have any opinion or any comment? Or else? So thank you all. Thank you for your excellent participation. And I would like to express my gratitude and our thanks from Bangladesh Eye Hospital and Institute to our great teachers, Dr. Adreti Rustam, madam. It's 7 a.m. in USA, and she is with us. Thank you, madam, for being with us. Dr. Shambhashila Murthy, madam, Dr. Sunita Chaurasia, madam, Dr. Muralidhar Ramappa, sir. Thank you, sir, for being with us. And Dr. Rajesh Fogla, sir. You are always a big name in Bangladesh. What I mentioned, thank you for joining with us in this webinar, sir. And our very own Professor Dr. Sarwar Alam, sir, Dr. Amiruzzaman, sir, and Dr. Rashid for joining with us and making the webinar a success. Dear audience, if you want to see any part of this presentation, you can go to the YouTube channel and can rewatch the program. And before the end, not but the least, I would like to express my heartiest thanks to Dr. Shambhashila Murthy, madam, Dr. Sunita Chaurasia, madam, and Dr. Adri, madam, for guiding me to arranging this webinar. Without you, we could not arrange this webinar. Thank you all. Thank you for participating. Thank you. Bye.
Thank you.
Bye.
Bye.